So welcome to PCEP for July 2024. Thanks to those who are here in person and everyone who's here online. Thanks in particular to everyone who worked the 4th. I feel like that's probably the most challenging holiday to work. So just a reminder from our purpose from the MPD office is to provide consistent, high quality care to our patients when and where they need it most. Today we'll go through a couple of updates and I'll talk through what we're going to talk about. So a couple of brief updates to start with. The bulk of the day is going to be about treating opioid use disorder and some new tools that we're putting in the toolbox. Oh, they see that? Okay. You guys able to see the screen okay now? Okay. So just to review, so a couple of brief updates. We'll go into treating opioid use disorder. We'll do some clarifications on some common protocol questions that come up. And then we'll talk about the protocol updates, which will go into effect on September 1st of 2024. So our brief updates. We have identified additional call determinants that will go straight to nurse navigation from 911 call. So that should ease some burden on the system. And then we've identified another group of call types that can be handled by the BLS 911 unit. And again, if a call goes to nurse navigation from dispatch and the nurse navigator feels like it can be handled by a BLS crew, that'll also be dispatched as a BLS crew. I do want to let you know that from the State Department of Health, there are rule changes coming. The primary one that's going to affect us is that they are going to require an EHR report on any EMS activation. Many of those may be cancels or no patients found. We're going to do everything from our office to make complying with that documentation requirement as easy as possible. And we'll give you more details about that. But I do want to let you know that that's coming. We expect them to finalize those rules sometime in July. And then we want to start getting into compliance as soon as possible. And then by the 1st of the year is when they'll expect compliance from everyone. So the bulk of the day is going to be talking about opioid use disorder. So I'm going to put this in the context of everything that we do and the ways that we can keep our patients alive. So I brought this up before when we were talking about heart disease. What are the leading causes of death in the US? So top of the list is heart disease. And obviously that's something where we can have a huge impact when patients present with their emergent heart disease. Next after that is cancer. That's something where we have less effect. And then CVAs. And then after that is accidents. And that includes both trauma and unintentional overdoses. And that is the area where we are seeing this incredible increase in the number of overdoses, especially from opioids. The number of opioid deaths that we have in the US right now is 6 times what it was in 1999. So this epidemic has come in 3 waves. So the first started in the 90s, and that was primarily related to prescription opioids, oxycodone, OxyContin, hydrocodone, morphine, codeine. And that was in response to, in part, aggressive marketing from the drug companies. But certainly as physicians, I think we have to take ownership for our role in this because we were marketed to and we increased our prescribing. And it has come down somewhat, but it is still high. The US has 5% of the world's population. The US consumes 80% of the world's prescription opioids. So this is an issue in many places, but it is most severe in the US. And some of that is cultural, some of that's the medical establishment. But so I want to be clear that, as a physician, I feel like this is something that we need to take ownership for our role in. But I think it was really striking to me. I mean, when I was in residency in 2012, I did a month-long rotation in South Africa. And it was very rare that you would see any opioids prescribed. It was basically for cancer around the end of life, maybe like a proximal long bone fracture. You would see that. But, broken hands, broken wrists, people were treated with NSAIDs and with Tylenol, and people do well. And so some of it has to do with expectation. But this practice has led to problems. So this first wave that you see here, starts around 2004. That's the natural and the semi-synthetic opioids, and kind of peaks around 2010. And then as the regulatory authorities started to say, like, hey, ooh, docs, you're overreaching, like this is too much. We're seeing problems, and we're seeing people become dependent on opioids, and we're seeing people overdose on prescription opioids. Then the docs started to pull back their prescribing. But people still had opioid use disorder because they had become accustomed to being on opioids. And so what we saw then is that people turned primarily to heroin. Heroin was cheap, easy, it was accessible. And so then the second wave of this opioid use disorder is heroin, and that's this lighter blue that you see here. And so, that peaked around 2016, 2018, and then it started to fall off. So I came to this, I finished my residency in 2012, fellowship in 2013, and that's when I came here. I worked a lot of nights. Pretty much every night that I worked, I would drain a shooter's abscess. I mean, there were people who were injecting heroin, and they were getting endocarditis, abscesses, all kinds of problems because of the heroin. And they were occasionally overdosing on heroin. I know all of you have run heroin overdoses that died. But it was the biggest complications that we were seeing in terms of the impact were secondary harms from using dirty needles, getting sick, getting abscesses, and getting really sick. And I'd seen patients who get an abscess in their spine and get paralyzed, and I mean it was debilitating. But what we have seen as replace that is fentanyl and other synthetic opioids or analogs of fentanyl, like carfentanil, things like that. But it's primarily fentanyl. So just think, if you were a drug dealer, what are the advantages of fentanyl over heroin? What's the advantage to a drug dealer of selling someone fentanyl rather than selling heroin? An online feel free to answer as well.
Cheap.
Yeah. And it's think about what's the concentration, like to get an equivalent amount to get people high. Fentanyl is so much more potent. So if you're smuggling a drug, it is much easier to smuggle something that's a lot more potent. And so there are economic incentives that push people towards fentanyl. And it is more addictive than heroin. In general, drugs that get absorbed really quickly, that have a really fast onset, tend to be more addictive. So if you look at the prescription anti-anxiety drugs, Xanax is a lot more addictive than Ativan because it has a quicker onset. And so, in general, docs are discouraged from prescribing Xanax because it has that quicker onset and because it's more addictive. So fentanyl is more potent, it's more addictive. And so we are seeing more people get addicted, but it is also, because it is so potent, it is easier to overdose on fentanyl. And so that's why we have seen, this is the third wave of the opioid epidemic. And we're seeing deaths from synthetic opioids go up and up and up. And I mean, and you see this every day you come to work. You're dealing with this, and it is something that is affecting more and more people. One thing I will say is that it is relatively rare to inject fentanyl. because people can get high relatively quickly by either snorting it, smoking it, or even ingesting it as a pill. So we have, at least just in my clinical practice, I have seen a lot fewer abscesses and endocarditis, things like that. But what we're seeing is people that are addicted to fentanyl and that overdose on fentanyl. And we're seeing deaths from overdose from fentanyl. So let's take a little bit closer look at Washington State. So you look at all of the injury deaths in Washington, traffic accidents, overdoses, 36% of the injury deaths in Washington are from overdoses. Nationally, it's 48%. So, I mean, and, we said that's of all the causes of death in the US, so about 5% are related to overdoses. It's about 107,000 people in the US in 2023 died from overdose. It is 9% of the hospitalizations are for non-fatal overdoses. It's about 4% of ED visits. It's about 7% of EMS responses. There's a lot of these patients end up not going to the hospital. They wake up and they refuse. And so that's part of the reason the EMS has such a key role to play. And focus down a little bit more even on Clark County. So of all the injury deaths, 29% are from overdoses. It's about 9% of hospitalizations, and about 3% of all the ED visits are for non-fatal overdoses. It is a significant chunk of our EMS response. This is the last 12 months of data. We have seen it go down a little bit, and whether that's because people are using Narcan on their own and not calling EMS, or but we know we're still seeing the same number of deaths. It's been a slightly smaller number of EMS calls. Who does it affect? It affects young people. So this is a last year of Clark County, who do we run on? And this is EMS gave the diagnosis of opioid overdose. The peak are people in their late 20s, early 30s. So, I mean, these are not just people who are dying. These are people who are dying who have potentially a lot of years productive life ahead of them. And then the last slide I throw in is what time of day do these come in? Again, this is not going to be any surprise to people who are running EMS calls, but these tend to be later at night. Peak starts to go up around noon, peak around 8 p.m. And then there's another peak around 1 a.m. That's when we see people overdose. So, in summary, background on the opioid crisis. So it's an increasing cause of death, particularly from synthetic opioids. And it's something that affects young people. So I think it's a chance that we have to make a difference. So how do you treat opioid use disorder? First, let's go a little bit into the chemistry of what happens with opioid use disorder. So basically, opioids stimulate your pleasure receptors. So in a normal brain, you have these endorphins, the endogenous morphine-like substances. It's like, that good feeling you get after a run. Those are endorphins. And that happens in a normal brain. Once you start using opioids with any regularity, then your brain becomes accustomed to this high degree of stimulation of those receptors. And so people don't die from withdrawal from opioids, but they wish they were dead because they just feel awful. People who are withdrawing, say someone you wake up with Narcan, what do they look like? Yeah, what are some of the signs you see?
A lot of it that, we don't run too many opioids here at District 3, but I think most of it, they're a little bit nauseous, depending how fast you push it. They can be sick, they can be confused. Most of the time they're pretty unhappy.
Yeah, they're unhappy. It feels pretty miserable. And so, and that's what drives the continue, like nobody wants to be addicted to opioids, but people don't want to feel dope sick. Like it feels so miserable that they will do almost anything to avoid it. And I mean, you've seen addicts steal from their family, break into houses, just because it's one of the strongest drives that we have as humans is I don't want to feel like that. So there are treatments for it. The treatment is a combination of medication and therapy. But what we have learned is that can't treat opioid use disorder without medication. It's a brain disease, it's a dependence. And so, we wouldn't say to a diabetic, like, toughen up, like, get your sugar up, get your sugar down. Like it is a brain dependence. And so we treat this with medication that helps to alleviate the cravings, that helps to get their brain back to that normal set point. And what we find is typically with about 2 years of treatment, people can ultimately taper off. There are some people who stay on maintenance treatment for longer. The average is about 2 years. So this is a joint statement from a number of physician groups, family physicians, pediatricians, addiction medicine specialists, psychiatrists about addiction. I just put the top 6 because I think those are the ones that are most relevant to us. So addiction is treatable. It is a long-term illness, but it's a treatable illness. No one chooses to be an addict. No one said like, I want to get hooked on fentanyl. Like it is something that whether you were exposed first by because you got a prescription or because someone gave you a pill of fentanyl, no one chooses it. But brain chemistry, it will change your brain chemistry. Some people have are more prone to addiction than others. And in general, people who have history of addiction, who have history of addiction in their family tend to be more prone to it. I know I have a history of alcoholism in my family, and something that makes me cautious. Addiction can affect anyone, and I suspect you've seen this as well in your practice. So, I mean, there are people who, who are in really rough situations who become addicted, and but there are people who have many advantages who still become addicted, and we do see this particularly with fentanyl. It cuts across all kinds of socioeconomic classes. Opioid overdose can be reversed. And so one of the key things that we can do in terms of harm reduction is to, it was both the Narcan that we provide as providers, making it available in the community, leave behind programs. We can help by recognizing the signs of addiction and encouraging treatment. So for us in EMS, we typically see it when someone is overdosed, but occasionally you'll come across someone who's just like, I feel like crap. I want to get off this. Like, help me get into detox. I want to go to the hospital, get started on detox. And then return to use is often part of the recovery process. There are very few things that follow a straight path. Like, maybe if you broke your arm and then it just gets better and better and better. But people who are diabetic have episodes of DKA, they have episodes of low blood sugar. They, people who have high blood pressure have times when it's controlled, and times when it's uncontrolled. So if someone relapses, it means that we haven't gotten them on steady maintenance treatment yet, but it doesn't mean that treatment is a complete failure. So what are the choices for treating opioid use disorder? The first treatment that was offered for opioid use disorder is methadone. So that's this picture on the left here. So methadone is a full opioid agonist. It takes a long time to build up. It's really long acting. People can overdose and can die on methadone. And so for that reason, it needs to be observed. It's dispensed in clinic. It also has another, like it prolongs QT, has interactions with other medications. And it has a lot of things that make it less practical as as treatment for opioid use disorder, but it still is an option. And there's some people who have had success getting off illicit opioids by getting on a regular regimen of methadone. On the other side, so that's full agonist. So naltrexone is basically long-acting Narcan. It blocks the receptor. And so people who are on naltrexone have trouble getting high. They have trouble overdosing, but it does nothing to protect against the cravings, or does very little to protect against the cravings that you get from your opioid addiction. So that's what buprenorphine is in the middle. It's a partial antagonist. So it has a lot of affinity for the receptor, but it only turns it on part way. So the way I think of buprenorphine, and I give both credit and criticism to ChatGPT for drawing this picture for me, but I was trying to get the idea across. Buprenorphine, so if you think that Narcan is the light all the way off, fentanyl is the light all the way on, buprenorphine is like a dimmer switch set to halfway. And so if you give people more bup, they just get to this set point. I looked yesterday. I am not aware of any deaths from buprenorphine overdose. I could not find a case report, because if people aren't, if their withdrawal isn't controlled with buprenorphine, you give them more buprenorphine. If people take a lot of buprenorphine, then they just tend to be like this set point where they're both protected against cravings and protected against overdose. How effective is it? So the number needed to treat is a measure of how effective stuff is. In other words, how many people do you need to treat to save a life? For example, number needed to treat for aspirin in someone who's having a heart attack is 36. Treat 36 people with aspirin, save one life. So for high dose buprenorphine, which is what we're talking about here, if for every 2 people you treat with high dose buprenorphine, 1 person will be in continued treatment a year later. So as far as treatments that we have, it's about as good as things get. It's not perfect. There will, not everyone will be treated, but for every 2 people you treat, 1 person is going to be steady in treatment for a year. And I think, when I think about this, I was reminded, I went to the National Association of EMS Physicians Conference in Austin, and I talked to a paramedic there who was on the community paramedicine team. And he talked about this woman, he'd woken her up with Narcan 20 times, and he tried to convince her to go, and she wouldn't go, and she didn't want treatment. And then they started their buprenorphine program in 2018, and he got her on buprenorphine, and she's clean. She's clean now. She was, the last time he woke her up, she was pregnant, and that got that, and the buprenorphine gave her the motivation to stay clean. And at the conference where he was presenting, he showed a picture of this woman with her 2-year-old daughter, and she's clean. And so this is something that has huge potential to change people's lives. So brief history on the background of buprenorphine in EMS. So timeline's not to scale, but in 2002 was when the FDA first approved buprenorphine as treatment for opioid use disorder. It was initially developed just as medicine for pain. It still is used for pain. It does have some pain control aspects, but it's this partial, this agonist, partial antagonist that makes it so effective as a treatment for opioid use disorder. So the federal government's Substance and Mental Health Office started advocating for more prescribing in 2013. In 2015, it was when ED pilot program started. And then in 2018, the first EMS program started. And so the pioneer program at Camden, New Jersey was the first one. Contra Costa County, California was the next one in 2019. Austin also started a program in 2018. As far as Washington State, Seattle has recently started a program. Spokane County, Clallam County, where Port Angeles has an incredibly high rate of opioid overdoses, and they've started a program there as well. So this is it is a pilot program. as far as the State Department of Health is concerned. And we're waiting on the final approval for our pilot application. But the state has said, they've approved multiple other programs. Our program follows what's been done in these other counties. So why do this in EMS? When you run on someone that gets woken up with Narcan, there's a 5.5% chance that person will be dead in a year. 1 year mortality from a STEMI is about 5%. I mean, this is roughly the same mortality as someone with a STEMI. They are telling you, I have opioid use disorder. I'm at risk for overdose. I'm at risk for dying because of the overdose. And in EMS, often we're the only people that have a chance to contact these patients. As you know, many of these patients refuse transport. And although we encourage them, we can't force them to go. And like you were saying, when we give them Narcan, we put them into withdrawal, which means that they're then a candidate to get started on buprenorphine because they're now in opioid withdrawal. They feel terrible. And so this is an opportunity for us to start them on buprenorphine. Obviously, nothing that EMS does happens in a vacuum. This is the Contra Costa County model for how they get people into treatment. And so starts with bupe administration in the field, leave behind Narcan. So bupe provides protection against overdose because it saturates the receptors, because it protects the cravings, but it makes it harder to overdose if someone is therapeutic on bupe. So if you give someone bupe, the chance that you will go back there in the same shift for another overdose is much lower. Leave behind Narcan, again, it's so Chief Milano, would you be willing to tell that story that you told me about leave behind Narcan?
Yeah, of course. So when you enter into that program, you have to do an intake with a DOH analyst. The analyst, as we were walking through the process, I asked him, like, what are some hurdles that other agencies have run into in an attempt to avoid that in our agency. And he stated that it was his 5th time of receiving Narcan before he got clean. And he had been clean for 10 years. So like I've alluded that to Katie and Pete, like out in the field, like as they're meeting with crews, because we have had some political fallout internally from, the Leave at Home program. And Pete has taken the brunt of that. But at the end of the day, I mean, these are the tools that we have. And, I'm excited for this program. And definitely in the city of Vancouver, we have a demand, we have a need.
Yeah, no, I think there's definitely a need. And so giving someone both either the Narcan you give them at that point or the leave behind Narcan, it's harm reduction. It's not the sole treatment for opioid use disorder, but you can't get people into treatment for opioid use disorder if they're dead. And again, these are young people. These are typically young people who have many potentially productive years ahead of them. And if we can get them into the treatment, we can help them. As we go through the protocol, ideally, these patients will be transported to a place where they can get a longer-term prescription. And we'll talk about how that'll work. So ideally, these patients will be transported. Some of them will refuse. You still, if you give them a dose of buprenorphine, you're still giving them about 24 hours of protection against craving and against overdose. And then this is, the giving the medicine in the field is the technically easiest part. I think this is the challenging part that we're working with our community to figure out how to do best. Is how do we get that warm handoff to ongoing care, whether they get transported to the emergency department or whether it's a community paramedicine team that's going out to follow up with them. There are many partners in the community who can prescribe and who can give the therapy, but it's making that connection between what we do in EMS and getting these patients into long-term treatment. I think that's at least, for me as an administrator and as a leader, that's the most challenging part to put together. So for that reason, this is how I'm planning to roll this out in Clark County. We're going to start with CARES co-response. I know we're going to miss cases. by starting with the CARES co-response. They have limited hours. They are not responding to all areas in the county right now. But that'll give us some time. My hope is it's on the order of a month or two to work out how we make that warm handoff, how we're consistently getting people into care. And then the plan after that is to go system-wide. So this is because it is a controlled substance, it'll be a medicine that is administered by a paramedic. And we'll talk through kind of what that'll look like. So this is a patient where you, so if you come on an overdose, see signs of respiratory depression, you treat just as we always have. You'd reverse overdose with Narcan. And then if the patient has signs of withdrawal, but you can also, I think it's going to be much less of what we do, but it is also possible, say someone just calls 911 and says, I'm withdrawing from opioids. They can enter into this pathway too. They need to be in withdrawal, and we'll talk about why that is. What are the signs of withdrawal? They tend to be restless, kind of shifting, kind of unsteady, like just can't sit still. They tend to be anxious or irritable. They tend to be tachycardic. They often have large pupils after either from withdrawal or after the reversal. A lot of times they'll have a runny nose. They can have nausea or vomiting. Yawning is something that you'll see with people who are in opioid withdrawal, and then they tend to be sweaty. More of these things, the worse the withdrawal. There is a scoring scale. I think that it's not necessary, and I didn't want to make this protocol more complicated or burdensome than it needs to be. In general, and in my practice, what I ask patients is, do you feel dope sick? Patients can tell you, and they look like that. Who right now are we not treating? Age less than 18. Right now, we are not treating pregnant people, patients with significant chronic liver disease, yellow, ascites, not just like someone with a history of drinking. If they're significantly altered, and that doesn't mean that if they did fentanyl, you woke them up, but you just need to be able to have a conversation with them. And then because methadone is really long acting, if they have taken methadone in the last 72 hours, we want to avoid giving them buprenorphine. So then what do we do? Would you like a medicine to help you feel better? If the patient says no, try to get them to go. There are other things we can offer them. They may ultimately choose to get buprenorphine, but we want to try to convince these patients to go if possible, but they can refuse. And would it be okay if the social worker follows up with you? We want to try to get that warm handoff in place. And then trying to get a phone number for them, especially if someone that's staying home, get a phone number for them. That gives our partners in the community a chance to try to connect with those patients. And then if the patient says, okay, I'll take the buprenorphine, then you can give 16 milligrams of the buprenorphine. It's a strip that goes on the tongue. You let it dissolve. Now, at that point, I would encourage you to transport. What we don't want to do with this is create really prolonged scene times. And say it can take some time to fully induce someone on buprenorphine. That's better done in the emergency department. Some patients will refuse, but we want to keep these scenes in general to 15, 20 minutes or less. So 10 minutes after the buprenorphine, you see how they're doing. And if they need another dose, you can give them an additional 8 milligrams. Treat nausea or vomiting, but if these patients aren't agreeing to the buprenorphine, then we want to try to refer them to the CARES team, because we know that these patients are at high risk for death. So we want to do everything that we can to get them into treatment. Not everyone will have a phone number. Not everyone will agree to have follow up, but we're just trying to help as many people as we can. Some people are not ready today to get help, but they may be ready tomorrow. then we'll document the response. Like I said, ideally, they can go to the emergency department. These patients can go to an alternative care facility like Rainier Springs. If they refuse transport, then flag them for as referral to community paramedicine and ESO. And then we'll look at other options for getting these patients into treatment. Questions about that?
So if a person agrees to buprenorphine, we give it to them, and then they're like, "Oh, I feel better now. I don't want to go." Right? So you give it.
Yeah.
That's just simply a refusal documented in your ESO narrative.
Correct.
Right?
Yeah, recommended transport. They refuse, and again, you still giving them some protection against overdose. And like I said, what we're working at is how do we then try to get some follow up for that and try to not completely lose that person to follow up. But even if the only thing that happens is that you give that person a single dose of buprenorphine, you've treated their cravings, you've protected them against overdose for 24 hours. Is that an issue? Okay. So some practical issues about buprenorphine. I mentioned it is a controlled substance. Will need to be in the knockbox. There are two formulations of buprenorphine. There's single agent buprenorphine, brand name Subutex, and then there's buprenorphine naloxone, brand name Suboxone. We're using them the same. Why? The reason. So when buprenorphine was first developed for opioid use disorder, the manufacturers were worried people are going to grind this, smoke it, they're going to try to get high off of it. And so they put some Narcan in that gets released when you grind it up. What we find, like I said, if people take a ton of buprenorphine, they just get really, really therapeutic on buprenorphine. So most of the addiction docs that recommend, if you have a choice, they say just use the single agent buprenorphine. It's if you're paying, if you're buying it from a pharmacy, paying cash in general, it is cheaper to buy the single agent buprenorphine. That said, some insurance companies only cover Suboxone. And so, but whatever formulation we're able to get, we'll use it the same because the stuff that we're really using is the buprenorphine. If this looks confusing, like they were really intoxicated with alcohol and then they did some fentanyl, or they were taking a bunch of benzos and then they did some fentanyl, probably better to avoid starting that in the field, just because when you've got multiple substances that you're working through, it's harder. This is better for just plain opioid withdrawal. And then we do not want to give buprenorphine to patients that are not in withdrawal. The reason for that is that because it gets to that receptor, it can cause precipitated withdrawal for someone who is currently high on opioids. Now, the treatment for that is more buprenorphine, but it's more complicated. It's more difficult. So our protocol is for patients who are in withdrawal, either because we gave them Narcan or because they were in withdrawal for other reasons. There are like dosing regimens where people can induce themselves at home with small doses of buprenorphine before they get into withdrawal. Other options like that. That's not what we're doing. We're just doing straightforward high dose buprenorphine for patients in withdrawal. Questions about that? Okay, so we'll keep you posted. So, the exact time of the rollout will depend a little bit on the CARES pilot first and then getting all the supplies in place. We'll work through any other practical issues that come up. We'll keep on fine tuning this as we go, but I'm excited about this. I think we really have the potential to help patients. And I think there are a lot of times where EMS is kind of rinse and repeat. We're doing this over again. We're doing this over again. And that'll never go away completely. But anytime that we can be like, man, I made a difference. Like I did this and now I'm not running overdoses at this house every day. I think that has the potential to make the lives better for our patients and hopefully to make our lives at work a little bit more rewarding and just a little bit less frustrating. Okay. I'm going to move on to common protocol questions we have. These are not changes in protocol. These are just questions that we frequently get, and then we'll go into protocol changes. I'd say the biggest question that we get is about hospital destination. So this is just a review of current protocol. So if patient is yellow or red trauma, you think, yeah, this patient is probably going to have some kind of traumatic injury. That is patient that's best served at PCEP, unless pediatric red trauma. For patients with STEMI or patients that have return to spontaneous circulation, you want to go to a hospital that has an open cath lab. So as of April 1st of this year, both of the hospitals in the county have cath labs, have cardiologists on call. Both of the hospitals will occasionally have downtime, either for lack of coverage or because they have a patient on the table. So check for STEMI divert. But both of the hospitals have been pretty meticulous about updating their divert status and being able to tell you when they can take those patients. If for some reason both Clark County hospitals are on divert with a STEMI patient, then you can go to the closest hospital in Portland. In general, if you have a patient in cardiac arrest, unless you're really seeing like a STEMI on your post RSC ECG, those patients probably go to the closest hospital. But if you see a STEMI on the post arrest ECG, then that's a patient that needs a cath lab. Severe GI bleed. So before January of 2024, Salmon Creek did not have 24/7 IR. That as of January 15th, they have had 24/7 IR. So the direction that we previously had about severe GI bleed, suspected varices, going to PCEP Southwest, now both hospitals have the same capability. It's the same interventional radiology group that actually covers both hospitals, and they both have 24/7 cath lab capability for these IR cases. So severe GI bleeds can go to the closest hospital. And then stroke, patients that need the comprehensive stroke center go to PCEP Southwest, or for some reason PCEP Southwest is on diversion for neurointervention, then you would go to a comprehensive stroke center in Portland. But as a reminder, LAMS 4 or 5, symptoms between 3 and 24 hours, comatose, profound paralysis, aphasia, suspected intracranial hemorrhage, age greater than 80. Any questions about that? And so with that, we'll go into the protocol updates that will go live on September 1st. So I'll go through a quick summary and then go into details, invite any questions. Okay. So with the universal patient care protocol, we just went into a little bit more detail about what the definition of the patient is, something that was occasionally coming up as a question. With the death in the field protocol, we are removing the requirement to contact online medical control for a patient that's persistently in asystole. For spinal motion restriction, after talking with the trauma service, everyone's now in agreement. For isolated penetrating trauma, spinal motion restriction is not indicated. For agitated patient management and also for post-intubation sedation, we're adding the RAS, the Richmond Agitation Sedation Scale, and we'll walk through that and how to use that. There's some minor changes on drug dosing and some clarification. We're adding in the mechanical ventilation and interfacility transfer protocols. So those all reside within the protocol app. Obviously, if you don't do interfacility transfers, then those don't apply to you. And then the mechanical ventilation is primarily for the transporting agencies. And then a couple of small housekeeping updates. Okay, so in the universal patient care protocol, we're adding in the definition of a patient. So it's someone who's requested EMS or has EMS requested for them. If a second party caller witnessed signs or symptoms which imply illness or injury, I saw him, fall off the second story. This patient, he was unconscious and he was seizing for a while. even if the patient is denying that, we consider that person a patient. Now, if a patient refuses to provide information, a patient can refuse to provide information and they may be a John Doe. But if you have someone saying something happened to make this person look like a patient, then we consider that person a patient. If the power of attorney or decision maker calls 911, if a healthcare professional calls 911, and then if you see someone in a situation that you in your training think is likely to lead to illness or injury, then consider that person a patient. Questions about that? So for death in the field, so we did get some clarification from the trauma service. If you see a trauma patient lose pulses, and for blunt trauma, if you can be in the trauma bay, like not in the parking lot, but in the trauma bay within 10 minutes when they lose pulses, those are patients where they will consider opening the chest. Survival for patients like that is like 3 or 4%, so it's not zero, but it has to be, within 10 minutes of when you saw them lose pulses, you can be in the trauma bay. To be clear, if you're transporting someone, that doesn't mean you stop transporting. If they're transporting someone, then continue on transporting. For penetrating trauma, because those are typically easier to fix surgically, they will open the chest up to 15 minutes if we have witnessed loss of pulse. Any question about those trauma criteria? And we've discussed that with the trauma surgeons. Those are the criteria that are recommended by the American College of Surgeons Committee on Trauma. And then for asystole, if you have an airway established, you have adequate ventilation, you started with asystole, stayed in asystole despite 3 rounds of epinephrine, then we know that these patients do not have neurologically intact survival, and then resuscitation may be terminated at that point. This essentially mirrors the protocol south of the river in the Tri-County area, and there are other Washington systems that have a similar protocol. Obviously, if you have questions or you're unsure, don't hesitate. You can always contact online medical control. As a reminder, just remember that you have asystole in more than one lead. But these are patients that we know are not going to survive, and we trust your ability to terminate resuscitation, connect the family to the appropriate resources there. Any questions about that? And then, primary goal here, one, we trust you to treat and identify these patients. We want to avoid any futile care, unnecessary transport. I think the key is that make sure you really do have an airway that's functioning well. Okay. For spinal motion restriction, not indicated for isolated penetrating trauma. Again, there's a joint statement from National Association of EMS Physicians, American College of Surgeons Committee on Trauma, and American College of Emergency Physicians. Isolated penetrating trauma, those patients do not require spinal motion restriction. This came up again, particularly in an MCI. This is something that can really, improve your ability to move patients if you have multiple patients with penetrating trauma. So decrease your resource utilization. And again, the goal is to just get these patients to the hospital as quickly as possible. Any questions on that? Okay. And Mark, any questions online? Okay. So I'm going to move into the Richmond Agitation Sedation Scale. So this is a scale that's commonly used in medicine. And the goal here is just to kind of take a bunch of different observations and try to coalesce them into something that's a single score that's easier to document. And so it's a range from +4 to -5. And it allows you to kind of paint a clear picture with a single number of kind of what's going on. So +4 is like a combative, violent patient, an active danger to EMS or to the community. +3, someone who's verbally, physically uncooperative. +2 is someone who kind of had non-purposeful movement when you move them, thrashing around. plus 1 is someone who's kind of restless, but not aggressive, not dangerous. 0 is alert and calm. That's where I hope to spend most of my time. And then -1 is kind of drowsy, basically wakes to voice. -2 is light sedation. So like you talk to them, they open their eyes, and then they tend to go back to sleep. Moderate sedation, like they'll open, they may open their eyes to voice. They don't like make contact with you. They don't track you. -4 is deep sedation, where there's really no response to voice, but if you stimulate them, you'll get some movement. And -5 is no response at all. And so the places this comes up primarily are when we are doing something that affects the patient's level of agitation. So, this was initially developed in ICUs for patients that are intubated. And it's a way that we know we can avoid delirium by keeping them like most ICU patients will be in that. They try to keep them around that -1 level, not so deeply sedated that they're likely to get delirious. For us, if you're intubating someone for a respiratory issue, then you're going to want to have them somewhere in that -2 to -3 range. If you're intubating someone because like they have bilateral femur fractures, then okay, go to -4, keep them really comfortable. Burns, go to -4. But it's a way to like clearly document how far down you put them with sedation and what we've got. Remember that if you gave a long-acting paralytic, your ability to assess this is going to be somewhat limited. And then we also use this for describing what's happening after we provide sedation to an agitated patient. We know that these are really high-risk patients. The Elijah McClain case is probably the most prominent one, but there are multiple other cases where patients that have received sedation from EMS have had bad outcomes. When you look at these cases, it is typically something that you hear me say a lot. Foundation of everything we do is good BLS. The thing that most commonly happens in patients that get sedation and have a bad outcome is that someone takes their eye off the airway. And it's understood. You're fighting, trying to keep yourself safe, but keeping that eye on the airway. And I think for the EMTs, like this is critical, like keeping that eye on the airway. Paramedic may be thinking about what medicines to give, where they're going to move the patient. Just keep the eye on the airway. And then our protocol, and this is not a change, that if you provide sedating medicines to someone, then as soon as you safely can, you put them on full monitoring, cardiac monitoring, pulse oximetry, and tidal CO2. This is a formulation that I heard a lot at the NAEMSP conference. Think of these patients like an RSI. These are patients that we are taking down their level of consciousness. We're at risk for decreasing their respirations, and so we need to watch very carefully watch the airway very carefully, watch what's going on with them, but what keeps these patients safe is typically good BLS airway management. And so then we document the sedation, so we know kind of what's happening with them and what's going on with them. ESO has an EMS index where they kind of compare things that indicate quality of care across the country. In their index for agitated patient management, the things that they look at are using end-tidal CO2 for patients that got that, and documenting RAS. So we just have clear, concise documentation of what we did to the patient's level of consciousness. Okay. With fentanyl dosing, this came up on a prolonged rescue where there was technical rescue. Took people several hours to get the patient out of there. The patient was having significant pain. So the max dose is 300 micrograms every 2 hours as needed for pain. For the vast majority of the calls we run, this will never become an issue. But if you are on a prolonged rescue, that gives you the ability to redose. For sodium bicarbonate, really two different indications that we're giving sodium bicarbonate for. So for a tricyclic antidepressant or Benadryl overdose, you've got significant sodium channel blockade. You're using the sodium bicarbonate to overcome the sodium channel blockade. If they've got a wide QRS, you're going to give it. If you see the QRS narrowing, then you can give it again. We'll talk through the practical aspects. That also may be an option to set up a drip at this point. But the key is it can be repeated if you're giving it for sodium channel blockade, like a tricyclic overdose or a Benadryl overdose. For hyperkalemia, it's a one-time dosing. The key treatment for hyperkalemia is the calcium gluconate. That's what's going to stabilize the membrane. That's the thing that's going to help narrow your QRS the most with that. Any questions on that?
Just one, if we have a patient who, long history of hypertension, that kind of stuff, are you okay with us assuming that what might be 120 for them might be a hypotensive state for them based on hypertension, or do you want us to stay with the, the MAP 65/systolic diastolic?
I mean, I think I would probably base it on their mental status. Like, if they're altered and you think that hypotension or hypoperfusion is contributing to that, then I think you could document like, okay, I think this patient is hypoperfusing and that's why I'm treating for that. But I think like if you look at the military's transfusion guidelines, they don't check blood pressure. It's all titrated to mental status. So I think that's what I would look at. But if someone's got a pressure of 120 systolic and they're mentating totally normally, then I wouldn't say that they're necessarily compromised unless they have other signs of hyperperfusion. But mental status is probably we perfuse our vein first. So mental status is probably the best indicator. Does that answer your question? Okay. And then the last, we added a reference to the state standing order for leave behind naloxone. So for those agencies that have taken advantage of the state's program where they supply the naloxone that you can leave behind on an overdose, we just put in a reference to that standing order. So, you're doing it within protocol and you're doing it based on the state standing order. And then housekeeping issues, as we mentioned, adding in the mechanical ventilation and the interfacility transfer protocols for those people that it's relevant for. I will take feedback on this, but our preference would be to remove the medication monographs. We all have multiple drug references. And so, that is not our strength as the MPD office is maintaining a drug reference. But I will take feedback on that. Obviously, there's, they're done, they're in there. If people really feel a need to have them in there, I'm open to considering that. But my goal is to keep the protocol kind of as concise as possible with the smallest amount to look through. Minor phone list changes. There's a single number that reaches the AMR supervisor, and then Dennis Schaefer is the new Fire District 6 EMS contact. Rather than putting the whole scope of practice list in the protocol, we have the link to the current Department of Health list, because that'll always be updated. And then we included a link to where you can do your mandatory reporting if you suspect abuse. Any other questions about protocol updates?
No, I don't.
Resuscitation limits, time limits for pulseless patients pre-hospital. The question is, does that have to be witnessed by EMS or can be witnessed by PD or the public?
I mean, I think if you clearly have a police officer saying like this person was awake and talking or like alive and they lost pulses, and you can be at the trauma bay within 10 minutes, then I think it's a consideration. But you need to really know that this person was alive, not just I saw him take a breath or he didn't look too bad or something. Like you need something really strong to say, because essentially you're gonna roll that patient in, and a trauma surgeon is, if they think this patient is viable, they're gonna crack the chest. They're gonna make a big incision along here, put rib spreaders in. They're gonna cross clamp the aorta. They're gonna grab the heart. They're gonna open up the pericardium, see if there's anything they can fix there, see if there's tamponade that they can do, and then And once that, either the patient gets pulses back at that point or they don't. But obviously that's an intensive procedure. It is a procedure that has risks. It is kind of a big whack that you're doing fast, and I've definitely seen people get cut doing that. So for the trauma surgeons to do that, they're gonna really convincing evidence that this is a potentially viable patient. Does that answer that question?
Is there any changes within Pulsera that transport agencies should notate to say this is someone who's probably directing it to OR, just let the charger make the decision when we roll in?
What I would say is like, blunt trauma, lost pulses at this time.
But Pulsera knows what that, don't
yeah.
check on it.
Yeah, because they won't even, they won't even go to the OR, they'll crack the chest in the trauma bay. And so they won't even go to the OR unless they get pulses back. And again, with blunt trauma, it has to be like they have a pericardial tamponade. They have something that you can fix pretty quickly by doing those things. Deliver the heart, relieve the pericardial tamponade, cross clamp the aorta, so that if there's significant blood loss from below, you can see if you can get a pulse back. With penetrating trauma, it's, it may be like, oh, I deliver the heart and like there's a hole and I'm gonna put my finger in it and then things get better and I'm put a stitch in that. So the odds are better with penetrating trauma, and that's why they extend that time. But the trauma surgeon is going to want to be convinced that this is a potentially viable patient. Other questions about that? So take home points. I think EMS treatment for opioid use disorder is a chance for us to save lives. I think we have the chance to make a really big impact on our patients' lives. And so I'm excited to do this. I know we'll learn stuff along the way, but I think it's an exciting step forward for us. In terms of the protocol updates, major one is that for patients in persistent asystole, after you obtain the airway, you can terminate that resuscitation without contacting online medical control. Spinal motion restriction is not indicated for isolated penetrating trauma. So if they, get shot and then crash, then you still would immobilize them. But if it's just a stab, a gunshot wound, that by itself does not require mobilization. And then RAS, the Richmond Agitation Sedation Scoring Scale, is a rating scale for sedation and agitation. We use it for agitated patients and for patients for whom we've performed intubation. It's built into ESO. And so hopefully we'll simplify your documentation there and get us all on the same page in terms of documenting that. And then with that, I welcome your feedback. I want to let you know, a lot of the feedback from the last lecture was that it's over the heads for the EMTs. And so I will continue to try to make sure that all of these lectures are applicable to everyone who's providing EMS care. But I want to let you know that I heard that feedback and welcome feedback on how this lecture did on that count. And any other questions? Thank you everyone for your attention. Appreciate it.